Oh, my name is Professor Bill Cumming and I'm a hand and orthopaedic surgeon. I'm proud to be a professor of orthopaedics in two countries, Australia and Indonesia. Carpal tunnel syndrome is extremely common in the community. I'd like to tell you about the bilge phenomenon. That is, we are like boats. When we stand up in the day and get about, the fluid collects in our legs. And when we lay down at night, it redistributes and equalises like the fluid in the boat when you tilt it to square. And so that fluid causes an increase in pressure in the carpal tunnel. Some people sleep with their wrist flexed, which may add to this pressure. Well, who gets carpal tunnel syndrome? And the most common presentation is a lady. She's in her menopausal age group. She's had several children and she's gained weight. There are other local causes for carpal tunnel syndrome, including pressure in the carpal tunnel, and it can occur with fractures or with arthritis or with other causes. But also people who are diabetic, hypothyroid, or other sorts of fluid accumulation phenomena, which are many and varied. The symptoms of carpal tunnel syndrome are nocturnal paresthesia. The patients wake at night and they have numbness and tingling and burning in their hands, and they shake them out the bed and do all they can. Sometimes they wake 2 or 3 times. It's very distressing. It's very rare to see carpal tunnel syndrome commence in the daytime. Extremely uncommon. And so we know that this nighttime problem relates again to this accumulation of fluid. The clinical signs that are interesting are firstly that this is a condition of the median nerve, which supplies 3.5 fingers. And the patient with carpal tunnel syndrome can tell you that in their ring finger, one half is good and the other half is bad. There are specific tests. The most common one that we use is called a variety of Tinel's test, in which we tap on the front of the wrist, like that, and the patient feels shock down their hand. There is also Durkin's test, in which we press with our thumb on the front of the carpal tunnel, and it's commonly positive. But the one that's diagnostic is called Phelan's test, which relies on flexion of the wrist like the patients do at night. And we do that in 2 ways. We either put the hands in the reversed prayer position, such as this, or we get the patients to put their elbows on the table, tuck them in close, and put the bad wrist or the both wrists under their chin. And they'll tell you that their fingers will burn, go numb, and that's a positive test within usually 1 minute or less. Well, we commonly need investigations these days in particular to confirm the diagnosis. And the first of these that we use is ultrasound. And ultrasound can be very helpful. The median nerve swells above the tunnel where it's caught or tightened, and it's usually more than 10 millimetres in diameter, and that's diagnostic, which is very helpful. The second test that we commonly do are nerve conduction studies. And in all patients who have a work-related problem, nerve conduction studies are an essential for a baseline. It's sometimes necessary to do an X-ray, and that's very helpful with the possible local causes, because arthritis in the wrist, particularly at the thumb base, is commonly associated with carpal tunnel syndrome, as are other local causes which can be assessed only by that method. The final test that we sometimes do, in unusual cases, for instance, where treatment's failed, is to actually assess the pressure with a needle into the carpal tunnel so that that can be tested accurately. That's unusual. Initially, we should institute conservative treatment. Surgery should be confined to those people who fail with conservative care. The first form of treatment which I think is of value in carpal tunnel syndrome is a wrist splint at night to prevent the wrist flexion. Many people sleep in the fetal position and they don't know that their wrists are flexed, and these can be very helpful. The next form of treatment which can be used if these measures fail is an injection of cortisone into the wrist. Now this can be of 2 values. Firstly, it can relieve the condition for some months. And secondly, if it is effective, it confirms the diagnosis, which is extremely helpful. There are several types of surgery, and some surgeons prefer a quite long incision in the front of the wrist, longitudinal. It must be very carefully placed to avoid the surface nerves. These days, and particularly in the hands of hand and wrist surgeons, we proceed to a mini incision type surgery. And there are special instruments that can be used so that this tiny incision can be used to release the whole carpal tunnel and can be all well seen. However, if you have any doubts about what you might find, you should proceed to open surgery so that you can see the median nerve. It is very important for the patient's return to function, activity and work for the incisions to be minimal. The results of surgery in carpal tunnel syndrome are somewhere between 85 and 90% successful in the general population. But unfortunately, this is not the case in the work-related patient. The results are almost the reverse. More patients are unhappy with their result in work-related patients than are happy. Many patients at work, working with their hands who develop carpal tunnel syndrome, assume reasonably that it's caused by that work. But if you think again of that bilge phenomenon, the fact that her symptoms are nocturnal and rarely by day, then we need to rethink which patients have work-related carpal tunnel syndrome and those which don't. The cause of carpal tunnel syndrome is not common at work, but the aggravation by work can be. And there are two conditions in carpal tunnel syndrome in which we believe is a factor. The first of these is working in cold environment. And this occurs in the seafood industry, where people are handling ice, in the poultry industry, where they're handling frozen food, etc. In these patients who work in cold environments, they commonly have bilateral carpal tunnel syndrome. However, when we come to the other factor, which is accepted, and that's vibration tools, then we need to look at the bilateral and the unilateral person. For instance, a lady working using a heavy polisher in a city building will get the vibration and the man working the jackhammer. And these are bilateral. But then of course we have the impact tools in men who work in the building industry with impact tools on a one-handed basis. And in these patients, they're commonly unilateral and the dominant hand is involved. There is much discussion about such factors as keyboarding and repetitive tasks. And it's true that repetitive gripping needs to be considered as a factor in carpal tunnel syndrome. And some patients driving, holding the steering wheel long term, can be a factor in aggravation. But how much of that is a real cause is really unknown. Finally, there are some local factors in the wrist we need to consider. Carpal tunnel syndrome commonly follows fractures of the radius or fractures in the carpus in that region because of the swelling that occurs following that. And sometimes we need to urgently release the carpal tunnel in such patients. And finally, there's the patients with arthritis. And thumb base arthritis is the most common arthritis in the upper extremity. In fact, probably almost the only one. And these patients develop bony spurs which poke into the carpal tunnel, which we know is not expandable. It's a very tight tunnel. And so these bony spurs can annoy the median nerve. So any local factor such as that needs to be taken into consideration in the final assessment of the individual patient. It's a very complex, multifactorial issue, and I repeat that every patient should receive the benefit of the doubt and that you should examine the whole patient. You get some very interesting and strange findings that satisfy you if you do.